I'd like to welcome everyone to this webinar, Bridging Continental Divides, Challenges and Opportunities in Head and Neck Oncology Practice in Low Resource Settings. It's brought to you by the American Head and Neck Global Outreach Service. I'd like to thank the American Head and Neck Society as well as Roche for sponsoring this, as well as the leadership of the Head and Neck Outreach Service. Mark and Samir helped develop this over the past year or so as they transitioned leadership in the service and committee. So the objectives are to advance head and neck cancer care through partnership between the American Head and Neck Society and head and neck surgeons globally. And today we'll learn about current challenges facing head and neck surgeons around the world and discuss some possible solutions to those challenges. To set the table a little bit, if you look at developing nations around the world, they account for 67% of all head and neck cancers and 82% of all head and neck cancer deaths. In the US, the American Academy of Otolaryngology supports 12,000 otolaryngologists, which accounts for about one otolaryngologist per 28,000 people in the US. While in contrast, in sub-Saharan Africa, there are fewer than 20 head and neck surgeons for over 1 billion people. And in Haiti, there's one head and neck surgeon that I know of who takes care of about 11 million people, and he's excellent. You'll meet him today. I pulled some World Bank data on development and developing indicators for healthcare systems to provide a little setting and background for this. And what you see are the nations represented on the webinar today and their per capita expenditure as of 2019. At the low end, you see Uganda spends about $32 per person per year, compared to the US at $10,900, and the world at about $1,100 per person per year. When you look at overall physicians per 100,000 people, at the low end, you see in Ghana about 0.1 per 1,000 people, compared to the US at 2.6 per 1,000 people and the world at 1.8. And if you look at surgical specialists, it's not registered in Ghana or Senegal, but at the low end, 1.1 per 100,000 people in Uganda, compared to 54.7 in the US and 30.5 worldwide. So to connect with some of our colleagues around the world and bring you some really diverse perspectives, we've actually asked some excellent panelists from around the world, so I'm humbled to be a part of this. Mary Sebelik is coming to us from Emory. Jeff Otiti from Uganda. Johannes Fagan, who you may know has led much of the work in terms of developing the African Head and Neck Society and Fellowship from South Africa. Patrick Jean-Gilles from Haiti. Evelyne Diom from Ghana. Pankaj Chaturvedi from Mumbai, India, Tata Memorial Hospital. And Anokye from Uganda, as well as Don Weed from Miami. So with that, I'll turn over the introductions to Dr. Weed and Dr. Fagan.
Thank you, Joe. It is my pleasure to introduce Patrick Jean-Gilles, who is head of the Department of Otolaryngology, Head and Neck Surgery at the State University of Haiti. And he's also the president of the Haitian Society of Otorhinolaryngology and Head and Neck Surgery, and a collaborator with our groups at the University of Miami and Thomas Jefferson, along with other collaborations, which I'm sure you'll hear about this morning.
And from my side, I'm going to introduce my African colleagues. Jeff Otiti, he's the grandfather of the group because he was my very first head and neck fellow 17 years ago. So he spent a year with me in Cape Town, and he's returned to Uganda, where he's now the head of the Uganda Cancer Institute Surgical Services, and he's also past president of the African Head and Neck Society. And then there's Anokye. Anna is based in Kumasi in Ghana. She's also a past head and neck fellow from Cape Town, and she's doing a wonderful job there. And she's also a past president of the African Head and Neck Society. And then Evelyne Diom. Evelyne is from Senegal, and she's also a past fellow of mine, and she's our current president of the African Head and Neck Society. And she's actually the convener of the upcoming so Francophone meeting, and joined with the African Head and Neck Society meeting in Senegal, which happens in June. So we've got three very experienced colleagues, who are working in Africa and teaching others. Thank you.
All right, and with that, I'll stop sharing my screen and I'll turn it over to Dr. Jean-Gilles.
So as I was saying, I'm very thankful for this opportunity to give a little speech about what we are doing in Haiti. And we're gonna try to give a very brief presentation of, I would say, what is left of our department, because what you are seeing, what you're gonna see is not what our department used to be. The ENT department in Haiti now is, I would say, because of all the political trouble and economical problems that we have, is not exactly what it used to be. So actually, we only have 3 consultation boxes, rooms for the whole population. And we are seeing at least 80 to 90 person per day. So we used to have a very decent operating room that was dedicated to the ENT surgeries only. But now we have to share only one room with other specialties like general surgery, orthopedic, and urology. So as you can see on the bottom middle, that's the containers. This is where we actually do our consultations. The bottom left is what actually, bottom top, I should say. This is what we used to have as the operating room, and this is what it's like now. So things are pretty bad actually because of all this. And regarding the inpatient facilities, we only have 3 beds for the whole population. So that gives you an idea of what we are going through actually. So next slide. Okay, for the staff, we have 6 faculties and 9 residents in training. So we have 3 years training program. And after the 3 years, so the 2 or 3, 1 or 2 residents will go to France and sometimes to the States for 3 months rotation, but in France for one more year for the training. Next one. So regarding the potential, I think it's very high. It's a very potential because this is the only training ENT facility and the only public ENT care center for the whole country. So that gives you an idea. So all the cases from all over the country will be sent to us. Next one. So the current state of training. So like I said, we have a 3-year training program. We do general ENT. We do ear surgery first. I mean, only the basic functional endoscopic sinus surgery. We also do head and neck. We do a lot of head and neck surgery. We used to start a pre-flap thing in 2016 with Thomas Jefferson and the University of Miami. And we had to stop because of the COVID 2 years ago. And of course, all the insecurity that we are facing actually. So we hope that, we don't know. I mean, maybe in one year from now, we will be able again, because it would be very hard for any team right now to come down to Haiti in a situation like this. And like I said, so after the 3 years, some residents will make a rotation in France and sometimes in the United States. And like I said, in France, that would be a 1-year training program and sometimes 2 years. And in the States, there will be a rotation from 3 to 6 months. We have 1 resident that went to Thomas Jefferson for 6 months and is back with us now as a faculty. Next one. And regarding the potential collaboration, the first that we are missing actually, also the equipment and a fellowship training program. Now, what we have to know is that there's a new hospital under construction. We don't know exactly when this construction we are in, and so they say it probably 1 to 2 more years. So from now on to those 2 years, we're going to have to deal with what we have now, and it's not easy. So thank you very much.
All right, thank you, Patrick. Perhaps we can move on to Dr. Otiti.
Yes, good evening, everybody. This is evening in this part of the world, and maybe morning across the globe. I'll just share my my screen. Okay. Okay, thank you very much. It's a privilege to be able to share our experience and our challenges and opportunities in Uganda. I'm Dr. Jeff Otiti. I am head and neck surgeon at Uganda Cancer Institute, and I'm also the head of surgical oncology at the institute. I'll first make a brief comment on my journey as a head and neck surgeon. I completed my residence in 2002 at Makerere University. Then it was the only university offering a postgraduate training or resident training in ENT surgery. And after that, I worked in the department of ENT in Mulago Hospital, which is the teaching hospital for Makerere University. And then in 2005, I was privileged to be the first head and neck fellow in the University of Cape Town under Professor Johannes Fagan. This is a Carlsto's sponsored fellowship. I successfully completed the fellowship in Cape Town and then returned to Mulago National Referral Hospital. When I returned there are of course challenges settling back in. For starters, we had just one ENT department with no subspecialties, and we share one operating theater, and head and neck surgeries were put at the back of the list, and most of the time will not end up being done. So it was quite frustrating. And there are many administrative difficulties as well as Mulago Hospital, as the National Referral Hospital. So for some time, I got an opportunity to work in Rwanda, where I ended up setting up an ENT department and a training program, a resident training program in Rwanda with some of our colleagues, and a fraternity from Germany. And I returned back to Uganda in 2013. So when I got back in 2013, I joined Uganda Cancer Institute to set up actually a head and neck unit. Now, the Uganda Cancer Institute started as sorry, just move the slides across. Uganda Cancer Institute started in 1967. It was started as a collaboration between the Makerere University, which is a teaching hospital, and the Ministry of Health and National Cancer Institute in the USA. And it started as a department in Makerere University, which was focused on treating cancers, but in particular, there was one cancer which raised interest, that was Burkitt's lymphoma. Dennis Burkitt was a surgeon in a British surgeon in Uganda, working in Uganda, and he discovered this tumor affecting the mandibles of children. And he took some samples to the UK, and after analyzing it, that's how it got its name. So interest developed, and even treatment was researched there, chemotherapy for Burkitt's lymphoma, and it was a success. So Uganda Cancer Institute began to grow. Later on, down the years, there are many other tumors which were focused on. Kaposi sarcoma during the HIV era became one of the focuses for Uganda Cancer Institute. So it was predominantly a medical oncology and a research unit. Then later on in initially it was under Mulago Hospital and Makerere University, and it grew slowly. But in 2013, there was a plan to make it stand alone. And it was given a self-autonomy in 2009, 2010, and 2013. Actually, it was now standing alone. It has a board of directors oversight and was reporting to the Ministry of Health. So Uganda Cancer Institute was mandated to provide a state-of-the-art cancer care and prevention by advancing knowledge and fostering use of research as a resource in training and professional development. Later on down the years, in 2016, 2017, we were selected because of our history in research and in cancer care to be a center of excellence for comprehensive cancer care in East Africa. So that helped us attract a grant from African Development Bank, which gave us quite a bit of money for infrastructure and equipment. And that's helped solidify Uganda Cancer Institute. I must say that before cancer care was not really consolidated. The radiotherapy unit was on its own. Medical oncologists were on its own, and the surgeons were working in the main hospital, and they were not talking together. So it was my privilege to come and set up a unit. Now, Uganda Cancer Institute has clinical services, medical oncology, pediatrics, pediatric oncology, surgical oncology, and gyne oncology. Initially, we had just one old Cobalt 60 for our radiotherapy services. And in 2019, it actually caused an outcry when that only machine broke down. And that stimulated the government to ensure that we got another machine. And with the ADB grant, we were able to even get an IMRT. So that was quite promising. So it has a fully established lab services just for cancer patients and with pathology. And currently, we are now able to do immunohistochemistry and some PCRs. It's developing a tissue bank and a full cancer registry. And we also have radiology services, mainly chest x-rays, ultrasounds, and CT scans. Not yet got an MRI, but we hope to get soon under the same grant. And we also do community outreach and screening services. This is what the Cancer Institute looks like now. The previous pictures showed what we were for a long time until 2013, when this building was built up. And then with one of our collaborations with Fred Hatch in Seattle, they have built another building, which is an outpatient building, which is really nice. When I got back, Uganda Cancer Institute was not really doing a lot of surgical oncology, and we were stimulated to start up something. And in that new building, we had a theater. It was a large theater. It was really not designed for operating big cases. That was not their vision. But when we started some collaborations, we actually were able to put up 2 operating tables in just one theater. And that's what we've been doing for a long time. There's a lot that will come as I will explain as we go along. On our left is our current ward. Now, we didn't have a ward as surgical oncology, and it took a lot of time to lobby and get something. So our trick here was to get a small space with just 5 beds, and we called it an HDU, and we're developing it as a high dependency unit, a surgical high dependency unit for immediate post-op patients. But as a whole, in all the other wards, they are overcrowded and many patients are lying on the floor and so on. So it became a bit difficult to do operations in such a situation. So we're lucky to have that as well. Just recently, that's when we got this ward. I must say, as we started head and neck oncology, I give credit to our partnerships, in particular, Dr. Chad Zenda and Katrina Hill is a team which does head and neck outreach missions. From the time 2013, when I got back, he came and he was visiting under Case Western Reserve University. And he saw where there was a need in Cancer Institute to really do head and neck. And he found me there and we started talking. And immediately we clicked and we were able to start up doing surgical camps. And since 2013, except in the last 2 years of COVID, we've been doing 2 surgical camps in Uganda together twice a year. The collaboration brought in loads of equipment, especially surgical trays and supplies, which were valuable in running these theaters. So we actually set up these theaters, and we showed that they could run well, even though we're sharing one space for two beds. With that collaboration, we were able to teach residents, and we are able to identify one of our colleagues who unfortunately passed on during the COVID wave last year, Dr. Ian Bwete. So Dr. Chad Zenda identified him as a very keen head and neck surgeon and took him up. With our previous collaboration with Case Western Reserve University, they've trained a lot of physicians, and they are not trained as surgeon. He was able to convince them to take him up in the United States, in Cleveland, and he spent a year, and where he was trained in head and neck surgery. As again, I say, unfortunately, we lost him. The gentleman who's next to him is Dr. Kaga. Dr. Kaga was his close friend, and is currently doing head and neck surgery in Cape Town under Professor Johannes Fagan. So we give a lot of credit to our partners in helping us set up a head and neck unit in Uganda. Right now, this is what we do in the cancer unit. We have a full day of head and neck tumor board. We really have new patients, about 10 to 20 new patients in those tumor boards. And then we also have another full day of follow-up clinics. And then we have 1 day of surgeries. We share in that same space with pediatric surgery, general surgery, gynecology. Each of them has a day. We're able to do 1 to 2 major cases and 2 or 3 smaller cases every week. Now that's with the ADB grant, there's a lot that's coming forward. We soon will have 3 operating theaters, now proper operating theaters with a surgical ICU with adequate ward space, and they're in the final stages of completion. And later on, there's a plan to also have 3 extra theaters for ped and gynecology. This is the planned look of the center, which is sponsored, which has been facilitated by African Development Bank, and we are really in completion stage. So we are really excited about that. So the challenges in building a head and neck service are many, as I mentioned, alluded in the previous slides. One is prioritizing surgical services. Uganda Cancer Institute itself was mainly medical oncology, and took a long time to convince them that we need to really have a focus. And we're lucky that our director eventually bought in and said, yes, if there's anything that changes the prognosis of cancer patients is really surgery. If you get them early and you can cure them. Head and neck surgery per se always falls back when you bring in other tumors, especially gyn tumors and breast cancer. So we tend to fall back a little. So, but we've been pushing, and we actually have been the light for the surgical oncology in our unit in Uganda Cancer Institute. The other challenge we have is staffing is thin, and this applies to most of the other countries. You really have very few staff. You'll have 1 nurse running a ward of 30 or 40 patients alone, even at night. I am the only head and neck surgeon. Soon, Dr. Kaga will join me for the population of 45 million. So more help is needed to really run successful camps. If you're intending to do camps, we usually try to get help from different other places, get some extra nurses. There's a lot of lobbying to do. National budget constraints do not allow easy hire of staff. There's a need to train all cadres, not just the doctors, but also nurses, so that you have them, properly qualified. Even biomedical engineers, All the other cadres are all need to be trained, and that is a struggle we continue with. We still take time to train our nurses, to teach them good practices. In our small HDU, we really try to get them up to speed. Equipment is a big problem. It's very slow in procuring any equipment. Budget allocations are erratic. When the government has some money, they will give you. Sometimes they will not have. So equipment support was very crucial for us. It's really a catalyst for growth. And our partners who brought us a lot of equipment really helped us in building our unit. We have many opportunities for training. Uganda Cancer Institute is offering fellowship training right now in medical and hematology oncology, pediatric oncology, and gyne oncology. We soon are going to be offering radiation oncology and head and neck surgical oncology. We're hoping to start a program this year. The opportunities here are really for those who are interested to join us in teaching, giving lectures online if you can't come. If you're able to join us during some of the camps, if you're able to mentor individuals, just like you find some residents who are really interested in head and neck, you can mentor them up. There's also opportunities for short placements or locums in the institute. The institute is hoping to have not just the main institute, but we will have satellite centers in 4 hospitals all around there. They are in plan, and one of them is already under construction. We hope the people who are trained in head and neck oncology in the center will go and boost services to the periphery of the country. There will be opportunities to actually have people do placements there as well to mentor the young surgeons. We are also interested in having, focused skills training. We had a short discussion about free flap before this started, but free flaps may be quite crucial for certain, tumors like the mandibular tumors, so that you can make patients a little more presentable, and skull-based surgery. Now, one of the reasons why we lose a lot as an economy with people traveling out for treatment is just because they need some of these more specialized, surgeries, which we may not be able to offer. During our camps, Dr. Chad Zenda came with a couple of teams who have been helping us, try to build up, free flap reconstruction. They actually use loops, they don't use any microscope, and it has been quite successful, and we really look forward to having some of that small section of patients who need it to be helped. We also hope to have surgical skills courses, and so opportunities for training are there. You can also help in training also the residents. Right now we have subspecialties, and head and neck is a subspecialty in the ENT department in Makerere University. There's also opportunities for research. As I told you, we started up with research in 1967, and our motto is that research is our resource. We, at the moment, do a lot, postgraduates do their research, those who are interested in cancer at the Uganda Cancer Institute, and we do a few clinical trials. But there's a need to have symbiotic relationships and mentorship of researchers. The research areas could include just general clinical care, clinical trials, basic science, translational research. In fact, we do have a lab coming up, and we hope it will be quite good, and there will be opportunities to really mentor some people in that. So UCI, Uganda Cancer Institute, aims to have to build clinician scientists career tracks. So we look forward to help our local scientists develop their full potential and climb academic ladders. In summary, I would say that there is a potential for collaboration. Under African Head and Neck Society, we are developing this fellowship in head and neck surgery, and we really encourage a lot of cooperation. There's still space for collaboration with surgical camps and alongside operating time with fellows and residents. There's also opportunities to develop, surgical skills, lab and courses to improve, our microsurgical skills and skull-based surgeries. And there's also research possibilities. We really hope to develop high-level research capacity and research scientists in collaboration with partners overseas. That is my summary. Thank you very much.
All right. Thank you so much, Dr. Otiti. And next we have Dr. Diom.
Good evening, everybody. I'm sorry so far my bad English. I'm going to improve it before our Congress and our meeting in June in Dakar. I am going to explain and speak about the experience in head and neck oncology in Ziguinchor. Ziguinchor is a city who is far from the capitals, 455 kilometers from Dakar. Dakar is the capital of Senegal. And it's very far, not only for the distance, but we have Gambia, the country Gambia, who is dividing Senegal in two parts. And the people, before having an ENT department there, they have to sometimes pass through Gambia or go around Gambia and coming until Dakar, and it was more than 555 kilometers. Since 2017, we have a new hospital in Ziguinchor. Before 2017, when I was I was affected there. I was sent there. Yeah, I was sent there. Before that, we didn't have a ENT department, only like a small center with a very basic ENT surgery. I mean, thyroid surgery, tonsil surgery, adenoid surgery, but not more than that before 2017. Since 2017, we create a department in the Hôpital de la Paix, is a peace hospital, and is a hospital level 2 in the terminology. Level 1 is a very basic hospital. Level 2 is just only gynecologist, and voila. And level 2 and level 3 is where there is research and academic function. The hospital where I am in the south of the country is there. We have academic things, but we have academic function, academic activities and congress. But because politically it's very slow to change an hospital to a level to another, that takes time, and that implicates also a loss of money, because the government give more money to a level 3 hospital than a level 2, and this money will help the hospital to develop the different departments. But we are in that trying to change that. ENT in all the country in Senegal, we are 52, but in the region we are only 2 ENT and one resident. This resident come for 6 months to one year, and he have a good exposure because we are alone and we have to work. We at the beginning, nothing, not a big ENTs or head and neck surgery, only visit, and slowly we improve head and neck surgery, and all the case of Ziguinchor and of the Gambia, because in Gambia we don't have ENT. The case from Banjul come to Ziguinchor because it's closer than Dakar, 2 hours for people from Gambia. Guinea-Conakry and Guinea-Bissau also, they come to our center. And we start also otology, tympanoplasty, mastoidectomy, and rhinology. I say that because we cannot say we are doing only head and neck surgery because we are alone. We have to also also try to take care about other ENTs patient. This is our infrastructure. What about before that? Yes, the department is close to a young university. It's an academic structure of 10 years now. It's a new hospital. We have one box for the visit consultation, another bigger box for functional test, audiology and all the stuff. We have one theater, but in this theater we have three smaller theater, but no only theater for ENT and head and neck surgery, like in Dakar, in the capital, or other cities where we have where they have a theater for only the ENT specialization, only department. Here we have three theaters for urologists, gynecologists, and we have only 2 days to do surgery because we have to compare to be with the others. For the research, what is the potential for research? Because it's a new hospital, a small team. We have independent wards. Students come. They have to do their thesis, academic memory, and works, and we have to do some academic works with this student, and also with the residents that the resident who comes from Dakar and stay with us during 1 year. When they finish their stay here in Ziguinchor, they do a study, and voila. Also, we see just that there is a different epidemiology, and because the population also is different, coming from different countries also, and little bit different habits and custom from the north of the country. And it's nice to meet in the north and to exchange and speak about this small difference. For the particularity, the precarity, low salary, because it's a very rural region, difficult to access. The problem maybe is the fault of radiation. No center for the chemotherapy and the radiation therapy. People, when we we have to send them after the surgery, they have to go to the capital to have an appointment there. With COVID, we learned to have a multidisciplinary committee with Zoom and the patient have quickly their appointment after the surgery. The problem is, maybe I will speak about the anatomopathology result that can take times, because we have only one, and it's a new one. It's anatomopathologic in the region. No free flap reconstruction also in this region, and voilà. We also see that less cancer also in the region. Maybe I don't know why, but when we do the comparison between the capitals and all the big cities around the capitals, we see that there are less case of head and neck cancer. Oncology, no, benign tumor, no, but cancer, we see that there is a huge difference and more case of otology, and also, voila, we see that. Our need, our need is anatomopathology fellowship. Maybe it's not what I have to tell that here, but we have we need more anatomopathology, genetician, radiation CT, free flap plastic competency, and oncology doctors, just to help the people to not to go until Dakar to have a complete treatment. I just want to add that is a young structure, but there is a huge evolution, because now people from all the region and the limit of region and the country, they know that now there is a center, and people now slowly knowing comes to this structure. And there is a lot of challenges for this new structure, and I'm sure it's going to be better. Thank you to Professor Fagan, to American Head and Neck Society, and thank you.
Thank you, Dr. Diom. Thanks for presenting for us. And next, Dr. Konney.
Good morning, good afternoon, good evening, everyone, wherever you are across the globe. Yeah, well, welcome. I'm Dr. Anokye from Kumasi, Ghana, West Africa. I would like to present on the experience of head and neck oncology practice in Ghana, Kumasi. So the population and the map of Ghana, okay, the map is on the right. Ghana is located in the West Africa, as arrow shows, and the population as across the whole Africa is also reflecting on Ghana from 2010 to latest 2020. The number of population in Ghana has increased from almost 1.5 times. Now the population is about 32 million. And when I came to Ghana from Kazakhstan in 1996, it was 23 million population. So imagine the population has increased, and the other issues have also increased with the number of population we have across. Where I'm working is, the name of the hospital is Komfo Teaching Hospital. Is the second largest hospital in the country. After the capital city, we have 1,000-bed capacity hospital with inpatient and outpatient department, almost covering all the specialties and subspecialties. In some departments, we have supporting departments. I'm talking about the ENT and head and neck surgery. So we have oral maxillofacial surgery available in the hospital. We have department of ophthalmology, neurosurgery, plastic, and the thoracic, and also diagnostic services like pathology with the immunohistochemistry that is available. We have oncology, which offers radiation and chemoradiation therapy. We have supporting services in ICU. Also, CT scans are available across the city, as well as MRIs. The number of CT scans and MRIs, surprisingly, as pathology in private sector are also increasing every year. So it's not that difficult to get all these lab services available, as long as you have money available, because the cancers are not covered by state or private health insurance. So all services and laboratories are also not covered by health insurance, except some few medications. So I'm presenting the hospital performance. for the last year that we did in 2021, you can see number of clients we attended at the ENT. We had overall 20 doctors at the ENT department. 20 doctors are from junior, those who have just completed medical school, up to the consultant or faculty level. So we had specialists and senior specialists. We are 8, which catered 16,614 patients, which made a ratio of 1 to 2,076 last year. The surgical performance indicator for ENT surgery to surgeons ratio, for the past 1 year, in 2021, we did 389 surgeries with 6 surgeons, which made a ratio 1 to 65. So we also analyzed the top 10 ENT OPD morbidities report for 2021. We analyzed what is the most common condition that comes to OPD ENT services. And of course, in Africa, the inflammatory or bacterial infection still stands very high and up. We have sinusitis, otitis media that is leading cause of presenting to ENT departments at OPD, and the children with their hypertrophy of tonsils and adenoids that needs special attention. If you combine neoplasm that stands at the folds and the goiter, then the figure that comes together to sum up becomes almost the second head and neck pathology, becomes the most second OPD morbidity in the hospital. And the number of patients we admitted last year, again, surprisingly, you see foreign bodies in ear, nose, and throat that needs to be admitted and procedure to be done is the most highest, followed by neoplasm. Neoplasm, they are all, we didn't classify head and neck cancers because the other non-malignant conditions were there, and somehow our biostatisticians has also divided goiter from neoplasm, but if you combine the two, it also becomes a most common cause of admission at the hospital. So at the department, it used to be a general clinic, but we now have also a specialist clinic. We have pediatric, thyroid, rhinology, head and neck otology, and tinnitus clinic. And the most common busy clinic is pediatric clinic with their inflammatory and bacterial infection, adenoids and tonsils. Thyroid clinic is also the busiest clinic, and head and neck is the third, fourth clinic, and being busy at the department. So those who come to us, there are categories of clients who walk in. You don't need to have any referrals to our department. You can just come and just walk inside and say you need service, and you'll be served with the doctor attended to you, and you can see majority of our patients have been referred, and they are about 82.50% have been referred compared to those who walk in. And we also analyzed that those who had been referred, are they within the hospital referrals or outside the hospital's referrals? And then we realized that those who came from outside the hospital referred were higher in number. So I also asked to pull out data from the oncology department for the last year, and the number of cases that we presented, you could see that number of cases that we saw at OPD with the head and neck cancers were 192. But those who managed to get to oncology department, which is separate departments, were only 99. So these 99 cases are all together those who need kind of palliative treatment, those who need curative treatment, they were all 99. So out of 192, only 99 reached the oncology department for any kind of, the treatment according to what the patient presented. So we also looked at the age distribution, those who have presented to oncology departments, and you can see the age between 50 to 59 and 60 to 69 were the highest, though you can also see children between 10 to 19 years, and then as far as people between 80 to 89 years were part of the oncology treatment of head and neck cancer at the oncology department. The types of head and neck cancer we saw last year at the oncology, and they were engaged by the treatments, were laryngeal pathologies, the neck, including, is not all unknown primaries, but neck, generally the neck nodes, anything on the neck, they lumped everything to the neck, and they became like, we still need to work on this data about the neck, but it became like most common, the second common cause of treatment over there. We have nasopharyngeal, oropharyngeal cancers, sinonasal cancers, esophageal cancers, thyroid cancers, and parotid cancer. These are not all the subsites of head and neck cancers, but I put it in a graph so that you can see the most commonest one, but the rest were just one or two patients, and I couldn't fit it into this. The cause of the mortality for 2021 at the hospital that we presented from the department, we had 8 cases of mortality, and also we have bacterial infection in the sinuses that were complicated to intracranial spaces, and of course the sepsis with deep space neck infection. We also had a mortality, but advanced head and neck cancers were about the most commonest cause of death on the ward, and these are the patients that when they present, they really are the advanced terminal stages that no matter what we're trying to do, and could not sustain or prolong their life. And I could say that the hospital also presented a data where they said the mortality for the whole hospital, the cancers were the second most common cause of death in the hospital after the cardiovascular system disease. So the cancers overall were the second most common after the CVAs and strokes. And again, on how the presentation on cancers and the death was, looks like gynecological cancers were the most commonest one in the hospital. So what we do in the hospital about the training or Ghana, we have a college that trains postgraduate, that is Ghana College of Physicians and Surgeons. We have also the West African College of Physicians and Surgeons that train ENT specialists. And recently, hospital has also engaged in subspecialty training in head and neck surgery, that we are in the progress of registration with collaboration of African Head and Neck Fellowship. And we also have school for ENT nurses. Since 2002, they graduated 450 trained ENT nurses that they are not only for the hospital, but for the whole country. And they are distributed to the rural areas to see and manage and recognize the most common pathologies in ear, nose, and throat, and give a basic support, basic treatments before the referrals, and identify those problems before the referrals to the tertiary hospital. And we also have audiology and speech therapy program in the university in the same city. So the collaboration or challenges still, as everybody presented, the user-friendly technology for preventing, detecting, diagnosing, and treating cancers in people living in low or middle-income countries, equipment and instruments needed as the hospital or the government are unable to procure the whatever required or needed to run the departments sufficiently. We also, in the future, see to have Center for Head and Neck Oncology infrastructure with a simulation lab, training service, and service providing for people with head and neck cancer, and then for postgraduates in training. We also look to outreaches and research in head and neck cancer or head and neck pathology areas. So these are this is my presentation. I would like to say, everyone, thank you for listening to me and have a good time.
That was great. Thank you. And thanks to all of our speakers. We really appreciate you taking the time to present your work and building your programs around the world. You know, it's amazing. In the US, I feel like sometimes we take it for granted that we can just get up, go to work, operate, and work within a very functioning system. And you guys have really done amazing work to build systems and to build healthcare around head and neck cancer in your countries and your institutions. And with that, I think I'd like it to open it up a little bit to some of our moderators to start off some of the discussion. So Dr. Chaturvedi, maybe you wouldn't mind starting with some comments or questions?
Yeah, so thank you, Joe. And I truly echo your sentiments that the colleagues in Africa are doing an amazing work. And there are many things that we take granted in our institutions, but hats off to all of you who have been doing an amazing job against the backdrop of all the difficulties and hardships. Now, Anna, what I realized from your presentation that you have a lot of laryngeal cancer and nasopharyngeal cancers. So I was intrigued that having a burden of nasopharyngeal cancer in that part of population is something, you know, needs to be worked upon. But what I didn't see was that oral cancer, you don't see many, though, you know, larynx, oropharynx, and nasopharynx continue to be the top 3 cancers amongst all cancer. And for Jeffrey, certainly, Jeffrey, I have visited your institution, you have visited us, and I really admire your passion and commitment. So perhaps any kind of support that you require in terms of training at our institution, we are there to help. India is just 2.5 hours away from you, and Joe and Donald are already there to help you in US, and we are there. So certainly, Anna, would you like to explain about why you have nasopharyngeal carcinoma? Is it Epstein-Barr virus related, or is it something else?
Yeah, thank you, Pankaj. A lot of research was already done, okay, before I became even ENT surgeon. And, you know, Ghana is located as a coastal by the sea. So a lot of people, like a staple food they eat is dried fish, and normally is freshly taken from the sea, and they dry, salted, and gutted. One of the causes that they found that is ungutted fish that they eat, especially those who introduce for children in weaning after 6 months, they grind that fish, which contains nitrosamine. And the other cause of the nasopharyngeal cancer was, of course, the Epstein-Barr virus cancer. So these are and those cancers are really common, especially if you take where Kumasi is located is not as very common as you see if you take a capital city, which is located by the sea in the coastal region. You can see the number of cancers with the nasopharynx is very, very high. So anyone who comes has a lump in the neck, in the posterior triangle, first thing in Ghana, we think that you have to exclude nasopharyngeal cancer until it is proved otherwise.
So thank you. It is over from my side. Joe and Donald, for you, carry on.
All right. Don, did you want to ask any questions?
Yeah, first of all, I would just remind all of our participants that you can put questions in the chat. I'm going to try and get those, as many as I can, up as well. But I did have a question for Patrick, Dr. Jean-Gilles. You know, we've seen a real diversity of resources among the presentations today, which is, I think everyone has done a great job of highlighting that. In particular, you're in an environment where you really don't have an effective partner in your government, at least not at the present time, and that's cyclical, obviously. But I'm interested in your perspective on the importance of collaborations, both internationally, and how you can accomplish what you're accomplishing without that kind of support from your resources locally.
Well, first thing, actually, I want to apologize because I didn't know that. I thought I was going to have only 5 minutes for the presentation. So that's the reason it was so brief. So if I knew that I would have more time, I would have make a presentation and give a better history of the ENT in Haiti. Now, the thing is, for now, I think it would be quite difficult for any, I would say, help from others right now, because the first slide that you saw is actually what is left of the ENT department. So we definitely need to wait for the new buildings. Like I said, we don't know exactly when the hospital will be and but for, you know that with all the problems that we have politically, we don't have any help from the government. So that's one thing that you have to understand. And we don't have any help from them. And actually, the ENT department has been destroyed by the Ministry of Works. So you remember the containers the way that they used to be, and now they are gone. They are gone, and one of the reasons is that the government wanted to open up the road, and the only way for them to do that was to destroy the ENT department, and that's exactly what they did. So so for now, it's quite difficult because we don't have any help from them. So even if somebody I have to be frank, if anybody wants to help us, I don't think it would be a good idea to help us in a situation like this, because if they have been able to destroy the department, so they can do anything. So I think we have to wait for the new building, and from there we will see what help we can have. So for now, we have to deal with what we have, and we have to train the resident in a situation like this, and it's not ideal. It's not the best way to train them. I think maybe it's a time for us to think about an alternative university hospital and to get outside of the university hospital. Like this, if there is any problem, so the residents know that they can go place else for training also. So like I told you, it's very hard.
It's incredibly challenging, and you've just done an amazing job there, despite all of that. Joe, let me turn it back over to you.
Dr. Sebelik, perhaps you would want to comment or ask a few questions?
Well, and I also congratulate all four of the panelists. I learned so much, and also learned about these incredible challenges I can't imagine facing. And Dr. Gilles, you just answered one of my questions. You are working so hard just to keep ahead of the stream of ENT patients who need your care. How can you possibly devote any time at all or energy to education? But you answered my question. You asked a very appropriate, important question as to whether there can be some off-site training to supplement. I just can't even imagine what you're going through. But along that same line, I learned a lot from Dr. Otiti about how surgical skills and lectures can assist you in your training program. And I think that's been one of my interests of the last 2 difficult years, is how COVID has pushed us into really opening our eyes toward remote training, remote education, remote skills training. And all the loss and tragedy that we've had, including losing our own colleagues, perhaps can result in more imaginative ways to collaborate globally. And so I want to put that out there, that I know myself and many of my colleagues are very available to collaborate remotely. Skills training, it's a lot of fun to figure out how we can do it. Dr. Diom mentioned lack of electricity as a challenge today. And basically we need electricity, a little bit of reliable broadband or internet, and maybe our cell phone cameras. And I think we can collaborate across the globe. So I learned a lot about who needs what, and perhaps some imagination how we can do more.
Dr. Fagan.
Well, thank you very much, firstly, for convening this, and thanks to the speakers. It was really wonderful to hear their challenges and what they're doing about it. The common theme when one goes to most lower income countries is that the big bottleneck for treating head and neck cancer is time in the operating room, simply access, and we heard that from all the speakers. And so 2 questions. One is to Patrick. Patrick, you spoke about introducing free flaps. Now, do you think that's do you think that's a sound policy in a situation where you're so resource constrained in terms of operating time? And then a similar question to Jeff Otiti. Jeff, when you have an overwhelming burden of cancer that you can't select everybody, how do you priority set? Who do you select? What criteria do you use to select patients? And I think this is a problem that colleagues from first world countries doing surgical camps often encounter. And they might make inappropriate choices of patients. So I'd very much like to just hear responses to those 2 questions.
Yes, sorry. Regarding the free flaps, the first thing that you need to know is that our statistics give us 4% of consultations of tumors of the face. So Dr. Curry and Dr. Weed knows a lot about that, because they used to come down to Haiti to help us. And trust me, we have so many people that needs surgery like this. I have a case right now. It's a lady, 51 years old. I mean, you should see that tumor. It's amazing, and she definitely will need a surgery like this. So even if we have those problems, but this program has to continue, because we definitely need that, and the people of Haiti need that kind of surgery. At once, I know that a lot of people didn't think that we could do surgery like this in Haiti, but with the help of Dr. Weed and Thomas Jefferson, we have been able, I think, we have been able to do 45 or 48 cases We lost some of them, but most of them was a success. So like I said, so even if we have those problems, but it's temporary anyway, and we have to keep on doing this program.
Thank you, Jeff. Would you like to respond to my question about how you select patients in a resource constrained setting?
Yes, maybe just to comment, our first line for every patient is really to use local or local flaps. And we've really trained ourselves to do almost all of them, really all of them. And that's our first priority. I think my interest though in free flaps is only to the difficult ones, especially mandibles. And what we've been doing in our camps for free flaps, we choose, you know, tumors which, I mean, like ameloblastomas, those which are not progressing too fast, and they can wait. They can wait for the camp. But we get the challenge of, you know, you have large tumors of the mandible, maybe squamous cell carcinoma. Those may not be able to wait, but you know they could be resectable, and that's the difficulty. Many of them, if it's just half of the mandible, we'll allow it to swing, and that's okay, and use a PEC measure, and it works really fine. But those which are involving the main term or getting more than 3/4, you know, they're still resectable, but you don't want to leave the patient in a worse position than they are. So that's where you really say that if there was anything I would do a free flap here, or you just leave the patient to pass on. For maxilla, we really do, you know, we use local flaps, you know, and they work very well. But total maxillectomy becomes a bit difficult and challenging. The other case which I mentioned really was you know, the skull-based surgery. Many patients will have to end up going out of the country, and we lose a lot of resources as a country sending patients abroad for certain treatment. So that is where the approach we come from. But first line is always a free flap. If a free flap, is a local flap. If it can work, I will always use that. It is faster, it's easier. It makes a lot of sense. Yeah, maybe that's my comment. Thank you.
Yeah, I think just from for Patrick to give some additional background, you know, there is no radiation in Haiti at all. So if you have a cancer that is more than a non-surgically curable disease, a lot of times the patients will leave the country. And so the patients that he'll typically choose for free flaps are just like Jeff said, they're large ameloblastomas. I think the largest one we did as a team was about 4 pounds, and it was in a younger patient. So he's tried to select those patients who could benefit the most from the resources. But with that, I actually wanted to open up to Don. Maybe you can pull some questions from the chat.
Yeah, I have one question for all of the panelists, or presenters, I should say. If they could comment about information, data, and support that would be helpful in advocating governments and ministries of health to increase support and prioritization of ENT head and neck care. I think we've heard Patrick's unfortunate perspective on that, but open that question up to the presenters.
So I think before the presenters can speak, Johannes, I think this is a wonderful opportunity that African Head Neck Society, American Head Neck Society, if we can put joint proposals to the governments and push and advocate for developing the head and neck cancer departments within the ENT departments to begin with. So I think it's a good suggestion, and perhaps Johannes, you being there for such a long time, you and AHNS and we all can work on this.
That's a great comment. Thank you, Pankaj. I don't know if Dr. Diom or Dr. Konney, would you like to respond to the question from Dr. Weed as well?
Oh, thank you. I think the advocating for the government and ministries of health to increase the support and prioritization of ENT head and neck care is good. The government recently, okay, so let's say about all the cancers that goes into the government, they really sympathize or get emotional, especially on like female cancers, cervical cancer, breast cancers are getting majority of the support, especially when the first ladies go and they are supported by first ladies of the government. Then children too comes a bit emotional. So a lot of things goes to say, but when you come with the head and neck cancers, and it doesn't go as compared to the other cancers, but still there is a room for us to improve and persist about prioritization of ENT head and neck cancer care. So I think as the time goes and then we are increasing in numbers, I think our voice will be heard more and strongly. So we hope it will come on one day. Thank you.
Thank you, Anna. But to advocate for or to help the government to do something. Here in Senegal, we have an association of the total laryngectomy, people who underwent total laryngectomy. They organize themselves with an association of around 300 person living with their laryngophone or esophageal voice, or provokes atos provokes speech. And we did some video in YouTube. We have some also public and mediatization for the population, for the public to know, to speak about the laryngeal cancer, the implication, the loss of the voice, the rehabilitation involves in social life, the health of the ministry start to help them to buy some laryngophone and start to have a little interest for that. I mean, because the register, the cancer, ENT cancer and head and neck cancer, they didn't have a big place in the register of the cancer in all Senegal. Maybe it's not touching a lot, comparing, for example, to death of women in the gynecologist things. They always compare this death with the ENT cancer. In Senegal, I mean in Dakar, the first ENT cancer is the hypopharyngeal cancer, is 50% of the cancer in ENT. It's a lot. We speak about the project to look for a viral etiology or alimentary etiology, but it's always, it's not, I think, a priority for the moment here. Thank you.
Maybe
could I possibly just add to Evelyne's comment about about the number of head and neck cases compared to other cancers. I think we've actually done ourselves a disservice by publishing figures for all the different subsites of cancers in the head and neck area that ENT takes care of separately. Because if you lump together all the squamous carcinomas of the upper air digestive tract and the salivary glands and the thyroids, which is what we take care of, then it's probably the most common cancer in Africa. And so I think it's all a matter of how we project our workload. And I think it's important that you lump all these figures together, and then we have a far stronger case to put forwards.
There's an interesting comment in the chat about, particularly, I think this is from Dr. Luganbuhl, I'm not sure, but efforts in Haiti are underway to bring radiation. Those efforts have really only gained traction, though, when they were connected to cervical and breast cancer. So while we are competing for resources, there's also the opportunity to combine forces with regard to need and bringing larger resources like radiation in. So an interesting comment there. We do have another question from the chat. Let me just see if I can get this. This is specific to Ghana from Dr. Safario. Do the head and neck cancers in Ghana tend to be general and smoking related, or are there major differences between the types of cancers and types of resources available between Accra and Kumasi?
Thanks, Donald. Well, again, those who are living at the coastal area, that is capital city, Accra, I think nasopharyngeal cancers are the most common prevalence over there, and laryngeal cancers and sinonasal cancers are also very common. Though some cancers are a little bit overlapping, but as from my data you saw from last year, the laryngeal cancers in our centers was the most commonest was. But the similarity are the same. Maybe if in Accra, nasopharyngeal will be the first, maybe Kumasi will be second or third, but between larynx, sinonasal, and sinonasal larynx and the nasopharynx, these are the most common type of cancers that we see. Majority, surprisingly, when I came to Ghana, what I was surprised, you barely see anyone smoking, but a lot of people come with the cancers. Still not sure, though some of them, but not everybody who comes with cancers, they smoke and drink alcohol. A lot of people don't smoke, don't drink, but they still get cancers. At their normal age group, like let's say laryngeal cancers in 50s, 60s, they still get cancers. And some are, they don't smoke, they don't drink alcohol, they still get the cancers. We don't see HPV-related cancers, though there was a study done in our center. The prevalence of HPV-related cancers are low in the center. So that's why we are saying the research is not very well done especially in Ghana. I can't see, I know Senegal, maybe those who smoke and drink, the frequencies are different. But in Ghana, something has to be researched deeply and genetically to see what is going on, because a lot of people don't smoke, don't drink, and then we don't also have HPV-related cancers. So there is something to be looked to, yeah. In terms of resources available between Accra and Kumasi, it's almost the same. Accra had a privilege to have a donation of laser machine, but I think that currently it's not working or there's something going on. But they had a laser that they could use laser for the laryngeal cancers at the early presentations. But we don't have laser in our center.
I was wondering, maybe, Johan, you could give a little perspective on how you've seen things change over the past decade or so, or what you think maybe the next most pressing needs are in Africa or for the African Head and Neck Society.
So I think the most exciting project that we've embarked, well, we've had two very exciting ones. One is just wrapping up on our resource appropriate head and neck cancer guidelines, because most certainly what's happening more and more as the first world becomes more and more high tech. The chasm between how we manage head and neck cancer patients in developing countries as opposed to first world countries is simply increasing all the time. So the guidelines promulgated by American or European or other institutions simply can't be applied. So that's the one. But the most exciting project that's on the horizon, and both Jeff and Anna referred to that, is the rollout of the African Head and Neck Society Head and Neck Fellowships. So we've designed a template for the African Head and Neck Society Fellowships, which includes procedures which wouldn't commonly be done in first world countries, and so these are being rolled out at 7 different centers around Africa. So hopefully, just as I retire from practice, Jeff and others will take over and and secure the future of head and neck training in Africa. I don't know whether Jeff would like to comment on it.
Yeah, I think it's a very interesting and exciting thing coming up. I think we will have a very high impact in cancer care if we train more and more. My experience is, when you do good work, more and more residents get interested in head and neck surgery. It's hard work, but they get interested. When you have good outputs, they get excited. To reduce the load on just one surgeon, you have to train more people. And my challenge is now to send more even to the periphery where the patients are, because distance is a challenge to many African patients. They may not come, they may not have follow-up. So we really need to focus on training with the experience within the center, but also in the periphery units, so that many patients can be picked up early. Those are things which give a high impact, and those are things which you can sell to the Ministry of Health. If you can, you can help treat, cure people who present early. That's the impact factor that many NGOs or governments are interested in. I think that's where we lose it in head and neck compared to breast and whether it's pediatrics and so on. They have a louder voice. They say we can have this impact, but we need to really have that impact. So training is a crucial thing for us as African Head and Neck Society, and that's what we're looking forward. And we really hope we can get more and more people trained and have an impact on the continent. Thank
you. Don, anything else in the chat?
Just a comment from Dr. Tedaveri that 95% of cancers happen in countries that together share 5% of the resources. I think a very sage point to potentially wrap up this very interesting discussion.
All right, great. Well, I really would like to thank everyone from the panelists, the speakers and the moderators, and everyone who helped plan this, as well as the audience for attending today. We really appreciate all the efforts that all of you made to get here and be on this Zoom. And then also especially like to thank our speakers, Dr. Gilles, Dr. Diom, Dr. Konney, and Dr. Otiti, for presenting their work which is really amazing, the efforts that they've made to build their head and neck programs around the world. Thanks, everybody.
Thank you.
Thank you very much. Thank you.
Thanks everybody.